I'd like to thank the organizing committee of this excellent meeting. I have the honor to share this important session. This session about breast cancer integrated perspective. We have very important topics in this session and very eminent speakers. Each speaker will have 20 minutes talk, and we will postpone discussion at the end of the session. The first speaker is Professor Ala Andil. My dear friend Ala Andil is a professor of clinical oncology. He is so active, especially in the field of breast cancer, head and neck cancer, lymphoma, and gynecological malignancy. He is also involved in Suzanne Mubarak Regional Center, especially screening program, breast cancer. Professor Ala Andil will give us a talk about management of breast cancer recently. Professor Ala, please.
Mr. Chairman, dear colleagues, first I'd like to thank the organizing committee, Professor Mariam, Professor Mustafa, and Professor Pereira, and the rest of the committee for giving me this chance to be with you. It's my pleasure and honor. Actually, the topic is so condensed, so I'd like to highlight on different aspects of recent updates, whether in terms of screening, diagnosis, and the management. We have a problem with breast cancer worldwide, and it's the highest instance, consisting of about 30% of all malignant tumors, and the highest in females. In Egypt, we have sort of an instance that came out from the Arabia Cancer Center registry, in addition to the most recent data that we got also from our national screening health program, Egypt-wide, and our instance so far is 42.5 women per 100,000 women. And this is somewhere in the middle between North America and Europe and Asia. We're not high and we're not low, we're somewhat in the middle. However, the thing is that the instance is so high in our females. Unfortunately, 10% of the cases and even more present with metastasis, the so-called very advanced stages. Average size at presentation is 5 centimeters, which is quite large tumor, and the average time for diagnosis is quite long. With a total population in Egypt of 85 million, nearly half of them are women, and about 5 to 6 million of those women are about the age of 45, meaning they need screening. So for an appropriate cancer screening program, it should lead to early detection of asymptomatic, not women complaining of something in their breast. They should go for the screening program with no symptoms, and the aim is to reduce mortality and morbidity. Benefits include improved prognosis, less radical treatment, reassurance of those women who have nothing in their breast, no problems, meaning negative tests, in addition to resource savings. With the advancement in the field of clinical oncology, actually we can talk about, in the year 2002 presented by the American Cancer Society, we can talk about 90% cure rate of all breast cancer. I'm talking about all stages, not stage 4 for sure. Okay? And to just highlight why is screening so important, in the United Kingdom, for instance, you can see the sharp decline in the mortality rate when they started their screening program in the year 87, and that's the same year in the States when they started that. It's a huge problem. And you can see from that, actually, at the beginning of the screening program in 1987, only 20% of the women of different subgroups did go for screening. It's a mental psychological problem for all women everywhere, not in Egypt. However, by enthusiasm and hard working, by the year 2000, nearly 70% of the women go to their screening test, which is extremely important. And the aim for that is to see some sort of a pie chart like that. This is the American pie chart, and this is old actually, by 96. I meant it to be old because it's much better right now. The majority of the patients have early stage disease, This is carcinoma in situ, which is stage 0, and this is stage 1, and this is stage 2, and all something like 9 to 10% is stage 4. Actually, our pie chart will completely be different. It will be stage 3 and 4, most of the cases. And our pathology colleagues and our surgical colleagues know that for by heart, actually. And the difference is huge, because this is the outcome of the disease at stage 1, which is almost above 90% cure rate, and this is the outcome less than this one in stage 4, less than 10% survival or cure rate. So it's extremely important to have a screening program detecting early as enough. Because actually it goes through so many phases, not as our average women always think that it comes in 2 to 3 days. No, it takes years for a breast cancer to develop. These are the different stages that a breast cancer or any cancer will go through to develop. And if you know that a 1 centimeter tumor has at least 10 to the power 6 number of cells, and you know that it needs about 30 or 40 doublings to reach that time, so it's an average of years for a tumor to reach 1 centimeter. As recommended by the American Cancer Society, screening includes 2 main things: clinical examination by an expert in the breast examination, in addition to annual mammography, plus or minus ultrasound or MRI as indicated. And breast self-examination is an option. However, if we try to apply that for all our women in a country like Egypt, actually with limited financial resources, that would be extremely difficult or nearly impossible for the time being. For that, we looked actually, myself, Professor Khargoush, Dr. Hana Ismail, at the screening program, increasing health awareness, getting those women in their areas, in low income or slum areas, if I may say the word, and to teach them all the facts about breast cancer, and to try to examine them and do a mammography as the financial resources would permit, in addition to doing a pre and a post test for those women. And the results were really amazing. We reached something like 4,000 women right now, but the analysis only for about 500 women. The first part was social demographic data, in addition to the second part that included questions about the knowledge of breast cancer and practice of breast self-examination. And that was by interactive lectures, as I mentioned, teaching them how to do the breast self-examination and do clinical examination for them. I will go through that actually very quickly. Just the 2 slides of the results showed that there was a significant improvement in the knowledge and the awareness of those women in these slum areas. So we can do something. I mean, we can do only clinical examination in addition to breast awareness, teaching them how to do breast self-examination, and according to the financial resources we can do them. Actually, several countries in the world are doing that, by the way. They don't insist to have mammography for all patients, only the high-risk patients, because they don't have financial resources. I will skip that actually, and then we'll come to the management and treatment. The idea of having one sort of treatment for all women or all breast cancer patients or any other type of cancer is very old. It's not fashionable anymore. It's like the one-size-fits-all approach to cancer. This is not true anymore. And why is that? Because breast cancer on its own is not one disease. It's multiple phenotypic diseases. And thanks to the new molecular and biological information that we learned through the years, we know that we have certain clinical criteria, including the stage, invasiveness, in situ component, the differentiation of the tumor, the nuclear plate, all the morphological criteria that we know. Lymphocytic infiltration, what kind of margins are we having. However, most recently, according to the molecular profiling, we can divide breast cancers into 4 main types, and they have completely different outcomes. We go through the luminal A and luminal B. These are the so-called hormone-responsive subtypes, according to the molecular profiling subtypes. We have the HER2 subtype and the basal cell subtype, plus or minus the triple negative, which is a very aggressive subtype. And actually that proved very true in genuine data coming from Netherlands, Norway, and Stanford from the States. This is the natural history of breast cancer. These are patients treated only by surgery, with no adjuvant therapy. Archived information actually, and you can see very clearly the outcome of those patients different between the worst outcome with this triple negative or basal and the best in the hormone responsive tumor, and that was very consistent in these 2 tumor data sets. That actually is the painting of, it would be changed according to molecular profiling. We should study the molecular map of every patient, not only the surgical anatomy. We also learned extremely important data about the HER2 family, which has a very complicated network through the cell. The HER2 family composed mainly of HER1, 2, 3, and 4, and it has a great deal with the cell cycle progression, proliferation, survival, and apoptosis. It's composed of 3 main compartments: extracellular compartment, transmembrane compartment, and intercellular. And with dimerization of this HER2 with another member of the HER family, through a certain cascade of events, it leads to gene activation, cell division, and all the bad stuff that we know about the HER2 breast cancer patients. These are all bad features actually, with growth and proliferation are increased, differentiation are decreased, cell survival increased, neoangiogenesis, and all bad features with the HER2 subtype, leading to bad clinical. And for that, American Cancer Society has stated very clearly that every breast cancer patient should have a pathological diagnosis of the HER2. So it's not only that we order the size, the tumor, the necrosis, the so on, the margins, the ER and PR, we should have the data for the HER2 new. Okay? And that actually proved in, these are major, very recent data about the adjuvant use of one of the anti-HER2 therapies, the so-called targeted therapy, showed very clearly the benefit of those, and that's actually, these 4 studies alone included more than 15,000 patients followed up for years and years, and the benefits was great using this targeted therapy. One other way looking into the cells is looking into other different cascades or different cell paths that leads to better or worse prognosis. Like for instance, the mTOR, one of the main actually pathways, the so-called PI3K, AKT, mTOR, which actually has a great deal of relation with the estradiol suppression. And most of the patients, when they have an increased mTOR pathway activity, they are more or less hormone resistant tumors, and you give the treatment and they don't respond. This is more or less the same slide, and for that actually, and this is very recent data again from the San Antonio breast cancer in last December, just 3 months ago, the Boleruto studies was trying a regular aromatase inhibitor, which is one of the hormonal treatments used in breast cancer, in addition to one of the drugs called everolimus, and everolimus is one of the drugs that would attack this mTOR pathway, okay? And the results were amazing actually, and those are called, because of the strength of the results, practice-changing results. You can see the difference between the outcome of those patients actually, because sometimes we feel helpless with some of those patients that can only be treated with hormonal therapy, they're not responding anymore, and you can give an agent like a targeted agent, and they do respond and live for years again and again. And I'm proud to say, and that data was presented by Ortobagi, this is a very famous head of the breast cancer division at MD Anderson, the famous institute. I'm gladly to say, I'm proud to say for all of us that I was a principal investigator at that study, myself and Dr. Rabab Gaffer from the NCI. We entered 6 cases in that study. This is a multi-center international study. One other targeted therapy is to attack the angiogenesis part of the tumor, which is the anti-VEGF part. We know that tumors have plenty of angiogenetic activity, and you can give some drugs like bevacizumab or Avastin, which stops that and deprives the tumor from its nutrition. And that's already FDA approved. One last but not least, one of the approaches in the recent advances in the management of breast cancer is the so-called neoadjuvant treatment or preoperative treatment, like you give treatment before the surgery. And that was a standard of care only for locally advanced breast cancer, but it's becoming fashionable in less stages and earlier stages. And the benefits is, number 1, to shrink the tumor and be more women applicable for conservative surgery and keeping their breasts. Also, induction of a complete pathological response, which is extremely important as a surrogate for the outcome of those patients. You can abolish all the tumor in certain type of patients for certain type of treatments, being chemotherapy, targeted therapy, and or hormonal therapy. And also, it's an excellent model for determining the activity of an agent. We don't have a cultural sensitivity in the field of oncology, and this can be a cultural sensitivity. You can rather than giving the treatment in the adjuvant setting, you can give it in an neoadjuvant fashion where you have the tumor still there and watch what's going on. This data have already been published earlier from MD Anderson, and you can see very clearly that the patients who achieve complete pathological response, the so-called PCR, do far better than the patients who achieve anything less than PCR. PCR means complete disappearance of the tumor in the breast and the nose, in the primary and the nose. and that was in terms of survival and disease-free survival. And this is more or less actually if they have negative breast and axilla, and they have positive breast and axilla, and anything in between, either still disease in breast or the axilla. For that, the targeted therapy is becoming more fashionable right now. So actually one of the studies again presented last year in the San Antonio Breast Cancer was talking about adding chemotherapy to this targeted therapy in different fashions. And I won't go through the details for you. I know there are not many oncologists in the room. But to see that actually, you can reach up to 50% or almost 46%. A complete pathological response rate if you combine two targeted therapies with the chemotherapy. This is extremely high. We've never seen anything like that before. But the amazing thing is that with two targeted therapies without chemotherapy, some patients cannot tolerate chemotherapy, you can achieve around 17%. These drugs are very expensive. Complete pathological response. And this is very much related with the hormonal responsive status of those patients being more in the hormone negative patients. However, the problem always comes how to select those patients. Which patients are more a candidate for this type of treatment. There are so many ways to do that. You could go by something like testing, giving 2 cycles and then see the response and then take it from there. Use the usual clinical pathological data that we know about, which is the hormonal responsiveness, the grade, the HER2, etc. Try to do some molecular tests like the DX21, which basically, you should know that more than I do, is taking 16 genes from the tumor sample in addition to 5 reference genes. That's came the number 21, and then come up after you do the certain testing for those genes with a score. And that score actually would put the patient in one of the risk categories, whether being a low-risk patient, an intermediate-risk patient, and a high-risk patient. This is a very sophisticated, tedious test, only done in one place in California, South California, and actually it gives a great help in determining what type of treatment can this patient have. Okay? So the patient with a low risk would lie in this group, intermediate and high risk. I'll go a little bit faster. Also, one of the ideas, can we correlate from the lab, getting data from the lab, about if this patient will respond to a certain type of treatment or not, whether it be chemotherapy or targeted therapy. Another study presented in the ASCO looking at different cellular markers in addition to different cellular pathways. I won't go through that, but the plan of the study was to do different lines of, one line of chemotherapy, different anti-HER2 therapies, the so-called targeted therapies, again, trastuzumab alone, dapatinib alone, or both of them, with the chemotherapy, do biopsy at time 0 before any treatment, after 2 weeks, give 12 weeks of treatment, 12 weeks of treatment, and then do the surgery, and then you have the third biopsy, and then you evaluate the response. How much a response did these patients achieve? Okay? This is tumor tissue processing. You will definitely know that more than I know. And these are the 5 cellular markers, in addition to pathways that have been chosen to look at and correlate between the response of the different types of treatment. And that was true actually. For instance, the first one, the EGFR type 1068, there was a correlation between that and the patients responding to lapatinib and oral anti-HER2 therapies, whether they achieve PCR, complete pathological response or not. The second one, which is FOX01, these are far complicated for us, but we know the names by heart. That triggers the cell cycle arrest apoptosis. Again, there was a certain type of ratio between the PTEN, another cellular marker, and the presence or absence of complete pathological CR. And the same goes for STAT5, which is another transcription factor. There was a correlation with trastuzumab between patients achieving complete pathological response and less than complete pathological response. And the autophagy pathway, another survival pathway in metabolic and hypoxic chemo stress, there was a correlation between certain ratios. That will give us actually the basic fact that was explained in Science in the year 2001, that the human cells, and especially the human malignant cell, is made up like the phone network. You know, phone networks are made up of different paths, different lines. So it's not that when you cut one line, the whole network will fall. No, they will use another one. And this is the whole idea of using more than one treatment for different patients. not to recur, because this is the problem for breast cancer patients and any cancer patients. And it seems that the patients who resist the treatment more have a smarter network. They can use more lines, and you can see this is the sort of network that the patients who achieve no pathological CR. It's more complicated than the simple ones for those patients who achieve PCR. And knowing that the tumors are heterogeneous, they are composed of different cell lines, different in invasiveness, in response to chemotherapy, radiotherapy, different targeted therapies, and so on. So we have to attack those tumors differently. We have to tailor the treatment. And that actually what the Austrian American group did. I will not go through that, but this is actually
what they did remaining.
So just trying those patients with 2 different chemotherapy regimens, evaluate the response after 2 cycles, and then shift them. Either they will go according to the initial protocol, regardless of the response, or will change the treatment according to the response we have. So the so-called response-guided treatment, which is extremely new, fashionable modality. And the difference actually, and the results were amazing. The patients who were guided according to their response did far better than the patients who did not. So these are the results, more or less. I'm just repeating myself in the slides, just for the sake of time. Last but not least, actually, the advances in the field of radiation oncology with the so-called 3D conformal radiotherapy or IMRT, intensity modulated radiotherapy. You can treat the organ like the surgeons do without harming the adjacent normal tissues like the lung. And
your time is up.
And you can see the difference in these slides. You can do some sort of intraoperative treatment, delivering the treatment even in the very small early case tumors during the surgical procedure. This is the right for every woman to have all the information and decide for herself whether she likes to keep her breast, if her case would permit, or she would go for a mastectomy, being young or old. This is again her right after knowing the information. I'd like to thank you so much.
Thank you, Dr. Alec. And now, Professor Dr. Basma Ishaq. Professor Dr. Basma Ishaq is the full assistant professor at the Department of Pathology, Faculty of Medicine, Alexandria University, and she will give us a talk about recent trends in breast cancer pathology.
It's a real pleasure and honor being in this prestigious meeting. Our talk is going to be about recent trends in breast cancer pathology. It's a well-known fact that adenocarcinoma of the breast is the most frequent cancer affecting women in both developed and developing regions of the world. Pathological examination of breast cancer specimens is and will be the gold standard for diagnosis in cancer. The role is to highlight the etiology, the pathogenesis, clinical pathological correlations, and prognostication. But we have to say that just the traditional methods of classifying breast carcinoma have relied only on the observer's ability to recognize features, how the nuclei look like, how the necrosis accounts for which percentage of the total surface area of the tumor, but prediction of the pathological or the clinical course of breast cancer is still by all means difficult. Traditional prognostic and predictive markers found out by the pathologist, traditionally speaking, we comment on axillary lymph node status. I'm not that tall. Axillary lymph node status, on tumor size, on tumor grade, histologic type, surgical margins, lymphatic and vascular invasion. We do write down something about vascular invasion, tumor necrosis, and lymphoplasmacytic infiltration. This is our homework. The pathologist, as they say, makes sense out of cancer chaos. We'll see in the coming few slides how we are making this sense. I went through our archives for our own knowledge. We do keep hard copies of the reports we issue. So in 1986, when I dug for some reports, my dear only anatomic pathologist in the room does recognize the neat handwriting of one of our most prestigious pathologists who happens to occupy a prestigious position nowadays. In this report, she states that this is an infiltrating ductal carcinoma of the breast with lymph node metastasis. All right? This is all we can get in 1986. More of the same in another report still in 86, also infiltrating ductal carcinoma with something about metastasis to axillary lymph nodes, and that's it. Jumping 10 years later in 1996, I think the same still held true, the same practice, infiltrating ductal carcinoma. This is the type with a very big or wide category of with lymph node metastasis, axillary lymph node metastasis. More of the same, and still we are in 96. Somebody did more homework here in 96, infiltrating ductal carcinoma, and she assigned a grade. It's a grade 3. All right? Please take care of the date. This is on the 6th of June 96. It's the same pathologist on duty for a week. And now she says infiltrating ductal carcinoma, and she assigns the grade, and she felt like it to state the exact number of lymph nodes. So what I am trying to make clear here is that it's all personal attempts at being good. Let's look at the word at the same time. When I found this, when I was preparing the material of this lecture, actually we found a 1983 backdating article titled Histopathology Reporting of Mastectomy Specimens, an Assessment of Interhospital Variation. It was, to my amazement actually, that just in half of the cases, or in about 50% of the cases, was histological grading assessed, and in just half to 2% at most was anything mentioned about blood vessel invasion. The authors put it this way, that recording histological grade in only half of the cases is clearly unsatisfactory by their own measures. And they happen to conclude that computerization of reporting and record keeping in histopathology is a recent development. We have to have standard questions to be asked. And this is how they saw the way out of this chaos. This is a picture of the dawn. Obviously, there was something in the dawn at this time, which is the standardization of the surgical pathology report. The way how we communicate with other fellows in the profession is through the report. It's our vehicle of communication. But still, there is significant variability in the format and in the content. To overcome these problems, people try to invent templates, checklists, and synoptic reports. The synoptic reports try to make a set of data of critical importance to whoever is concerned in a consistent and easy manner, no matter what the institute that issued this report might be. And this is an example of a synoptic report that we very much follow since the year 2005 in our department. It is adopted from the Royal College of Pathology. There are definitely other reporting performers by the Association of Anatomic and Surgical Pathologists in the States and so on. We are returning to us again, my department. This is the way we started implementing the reporting pro forma. I have to admit it was quite raw in this time, back in 2006, but still there are important bits of data that are listed. We have the type, we have the grade, and we have the exact number of lymph nodes mentioned, and going up a bit there is something about in situ component, which is important. The present. This is a report issued in this very month. I think the whole process is neater, and something about the exact Nottingham score is being mentioned. Let me discuss with you here exactly what we mentioned in our final phrasing. We mentioned the tumor type, and we give the exact grade, the exact Nottingham scoring system, something about lymphovascular invasion, the exact number of lymph nodes involved, with some mention of the perinodal invasion, and a comment on the background breast parenchymal condition, let alone that we do mention the exact amount of in situ component and the nature of the margins and whether microcalcifications are there or not. Good job, I believe, but good diagnostic job so far. So is this enough? Beyond morphology, there is still more homework for the pathologist to work through. Hormone receptors. In an article published 1896 by Beatson in Lancet, he mentioned for the first time something about breast cancers regressing after the surgical removal of a patient's ovaries. This established or is considered to be the earliest association between a patient's hormone status and the prognosis of breast cancer, only to be formalized in 1975 with the first correlation between expression of estrogen progesterone receptors and the patient's prognosis. To highlight it in a minute or in a word, ER and PR status are of more favorable prognosis when they are positive, and they definitely highlight the utility of endocrine therapy to follow. What do we do in our department? If it is of any interest to anybody, we do issue the exact hormonal status depending on the Allred scoring system, but unfortunately it is not done straight away like this. It is upon patient's request because of financial considerations. HER2 neo. Investigation into the genetic changes in mammary carcinoma identified application in a gene, this is the HER2 neo gene, whose overexpression meant poor prognosis. Additional experiments in the same subject came out with the results that monoclonal antibodies against HER2 neo inhibited the growth of HER2 neo transformed cell lines, and this actually was the laying of the foundation for the use of trastuzumab, with the necessity for us to play a very accurate role in diagnosing the exact status of HER2 neo. We do that in our department again. This is a picture of another dawn. We have something in the horizon. Molecular pathology. Dictated a newer role for the pathologist. The newer high throughput technologies, plus the realization of how heterogeneous breast cancer is, as Professor Amdeen said, it is not a single disease, it's a group of diseases. This all put together shifted the focus from diagnosis in our profession to prognostication. We had to identify morphologic features and immunohistochemical markers that were of prognostic relevance. The microarray-based gene expression profiling actually did confirm this fact that breast cancer is by no means a single disease, and that the different molecular subtypes display distinct gene expression profiles. The bottom line is with different prognoses. And this led to the expression profiling and molecular classification, what you call molecular taxonomy. Generally speaking, this made us, instead of discussing the squamous carcinoma of olden times or the lobular and the ductal, we are now speaking a different language. We are speaking a luminal A, luminal B, a basal-like, a HER2, and some skeptic normal breast-like type. To us, this makes sense, and I hope it does to all of us. This is a kind-looking breast pathology, and this is very good expression of ER and PR and nothing about HER2. In summation, this is a luminal A cancer. This is nasty, as histology is concerned. But still, it has something to do with ER and everything to do with HER2, and this makes it a luminal B. So we are translating pathology and immunohistochemistry into molecular, which makes sense. But why the fuss, as we say? Why bother? We bother, of course, because at least some of these types, if we were successful to put them in their relevant categories, do have their distinct risk factors, their clinical picture, and their histological features, especially response to therapy and different outcomes. In a glimpse on one of these groups, the basal-like, if you are able to state that this is a basal-like breast cancer, then you are saying the following. It's a triple negative phenotype, that is, it completely fails to express ERPR or HER2. Usually it occurs among pre-menopausal younger African Americans, and it has got ITC-NOS, known by any pathologist, the infiltrating ductal carcinoma, non otherwise specified pathology under the microscope. It's a high grade. Radiologists do identify it's aggressive, and it does pursue a very aggressive clinical course, usually not responding well to standard adjuvant therapies. We can foretell this from the start by histomorphology and by immunohistochemistry. And this is how we do play the role of fortune tellers these days. Pathologists now have the additional role of identifying biomarkers responsive to therapeutic manipulation. Again, the one size for all is falling, and instead the surge of tailored personalized treatment, the use of multi-gene signatures. Working as an indispensable member of the multidisciplinary patient care team, myself and others, the surgical pathologist can morphologically triage tissue samples to the most appropriate molecular tests. So we do have multiple roles these days, anatomic pathologists, I mean. A role in diagnosis, in prognosis, and in guidance of therapeutic decision making. But one can't help it. While preparing again the material for this talk, you come across a title like this. Anatomic pathology is dead, long live anatomic pathology, and something like the role of the indispensable surgical pathologist in treating or in treatment planning for breast cancer. This just makes you feel humble. Thank you very much.
Thank you very much, Professor Basma. Now we'll move to our next speaker, Professor Ahmed Mustafa. Professor Ahmed Mustafa is the assistant professor of genomics and bioinformatics in the Department of Biology and Biotechnology in the American University. Professor Mustafa will give us a talk about bioinformatics and systemic biology. Please.
Good morning, everyone. It's a great pleasure to be here today. So my talk will actually focus on keywords that Dr. Ala and Dr. Basma mentioned in their talks. High throughputness, molecular profiling, and metrics. So the type of medical systems, biology, and structural regulation. So systems biology is all about networks. So systems biology means that we take the system, we study systems from the systems point of view. It's the opposite of the traditional point of view, which is the traditionalist point of view, where the scientist or the investigator has a specific gene of interest, and the scientist works on the characterization of the gene. We go from reductionist to holist, meaning that, again, we study all the components in the system. So when we talk about cell, the components of the cell. So when we talk about the cell, the components of the cell are the transcripts, RNAs, nucleoles, proteins, metabolites, enzymes. So when we study the system, when we study the cell, we want to look at all the components of the cell and the interaction between the components. And the interaction between the components gives us the network. So So what are kind of networks are we familiar with? We're familiar with the social networks. So that's an example for a Twitter network. Another social network, Facebook network. So these two guys are pretty social, as you can see. That's my LinkedIn network, not so social as the two previous people. So what can we see in the network? So the network is simply nodes. So the nodes are the elements or the components. So when we get to the cell, the nodes will be either transcripts or proteins. The components are linked by edges. Okay. So the edges mean, so when we talk about the protein interaction network, so the edges, it means that mean two proteins are interacting with each other. When we talk about transcripts, so the edges between the transcripts are going to be regulation between genes. We can see in the network kind of clusters. Okay, so elements or components in the network are clustered together. It means that they are involved, probably they are involved in a certain biological process. So we have network and we have clusters, and the nodes represent the components, and the edges are the interaction or regulation of the components. So here's a very famous picture for the human interactome. So the human interactome means all kind of protein-protein interaction in the human cell. So there are more than 100,000 interactions in the human cell. So again, each circle represents a protein in the cell, and the lines between the proteins it means that there is an interaction between the proteins. So that was a protein-protein interaction network. Here it's a transcription network. So transcription network means that one gene regulates the other gene. That's a focus or zoom in small part in the transcriptional network in E. coli, in bacteria. So biological network, in whether it's a protein-protein interaction or transcription regulation, it's very different from a random network. So when you look at a random network, the nodes in a random network are simply connected by each other in a random. There is no much difference between the nodes within the network. But when we look at biological network, it's very different from the random network. So we can see that there are certain nodes within the biological network or the significant network or the non-random network where that node is connected or related to so many other nodes in the network. Okay? So we have few blue circles that are kind of having high degree of connections to other networks, and very few nodes are connected with. So many nodes in the network connected with only one or two other nodes. So in a random network, the degree of the nodes, the degree of connection, it follows kind of normal distribution. In a biological significant network, we don't have that randomness. We have very few nodes connected with so many other nodes, and most of the nodes in the network connected with very few nodes. So when we get the network, when we generate the data and we look at the network, what we want to see in the network, we want to look in the network for these kind of motifs, they call it motifs, components within the network. So when we see a gene that regulates itself, what can we understand about genes that regulate itself? So probably it means that that gene, when it starts regulating itself, then it doesn't need any more the signal that induces the transcription of that gene. So it switches the transcriptional network of the gene from on to off and sustain the regulation to on. So here's another motif where we have a kind of feedback loop to provide feedback to stop the regulation of a gene. We have that motif feed-forward loop. Okay, so why would we have a gene that directly regulates another gene, and the same gene gets regulated indirectly by the master regulator? What does it mean? So it could mean that the regulation of that gene it needs some delay, or it needs to wait for some time to get direct induction from the master regulator and through another indirect regulation from SY4 here, for example. Okay, so when we generate the data and we look at that huge network, we want to focus into the small components to understand what's going on in that transcriptional or protein-protein interaction. So again, the two types of network, but we're talking about the protein-protein interaction, transcription regulation. There are networks of metabolites, networks of phenotypes. So if we go back to the central dogma of biology, so very simply we have the DNA transcribes itself to RNA, and then RNA gets translated into protein, and the protein gives us what we are looking for, gives us the phenotype. Okay? So if we consider how many genes in the human genome, in 1998 was the first eukaryotic genome to be sequenced was the C. elegans, the worm, and when they finished the genome, they figured that there are 19,000 genes in the C. elegans genome. In 2000, when they finished the genome of the fly, they learned that there are about 14,000 genes in the fly genome. In 2001, when they generated the first draft of the human genome, so looking at the complexity between a worm and human, as the expectation when they finished the human genome to find about 100,000 genes in the human genome. But when they finished the genome, the surprise was it was only 24,000 genes in the human genome. Okay, so can 6,000 genes between 19,000 to 24,000 explain the complexity between worm and human? No? Okay, so that difference in genes cannot explain the complexity between the two organisms. So I can say that gene number doesn't translate into human complexity. So where the complexity comes from? So the complexity comes from the gene regulation. So all the cells have the same set of genes, and the complexity comes from the transcription regulation of the genes. So different body parts will have different expression patterns. So that's a spatial regulation, temporal regulation, different developmental stages from embryo to adult. A response to different environmental factors, transcriptional regulation based on the disease status between cancer and normal. Okay? So gene regulation is a key factor in terms of complexity. There are different ways, of course, to do the gene regulation. We have transcriptional-based regulation, post-transcriptional-based regulation, like microRNA regulation, translational regulation, post-transcriptional regulation. So if we look again at the central dogma of biology, so we have the DNA transcribed to RNA, translated into protein, and the protein gives us the phenotype, which will be most significant in terms of biology, in terms of the phenotype. So of course, the phenotype is the most important part. That's what we want to study. But in terms of easiest to study, which would be the easiest? So the easiest to study is the DNA. In between the two extremes, we have the RNA and the protein. So the DNA itself is a static component to the cell. All cells have the same DNA, so it doesn't reflect into the phenotype directly. And the phenotype is not easy to characterize between, let's say, different cancer subtypes, as we saw in the pictures in the previous talks. Okay, so as a good compromise between the two extremes, between the static component in the cell, the DNA, and our most significant part, which is the phenotype, we can deal with a good compromise with RNA. RNA is going to represent the dynamics of the cell. Different cells or different conditions will have different sets of transcripts, and it's much easier to isolate and profile the expression patterns with RNA than with protein or looking at the phenotype again. So gene expression, we can look at gene expression again as a good compromise, because we assume that the gene expression level corresponds to the protein level. The assumption that normal cell has a standard profile, and when we study the profile of the disease, we can compare the two expression profiles and understand what's going on in the, let's say, normal against cancer. When we take the expression profile for a cell at a certain point, it's a snapshot of what's going on in that cell at that time. So, in conclusion, gene expression is a good proxy for what's going on in the cell in terms of transcription and translation. Okay, so by looking at transcriptional or gene expression in a high-throughput fashion, so we're talking about the transcriptome. So the transcriptome simply is all transcripts in the cell. So if you isolate total RNA from the cell, now we're talking about the transcriptome. And the elements of the transcriptome are the coding part, which is the messenger RNA, and the non-coding components, non-coding ribosomal RNA, transfer RNA, and other non-coding RNAs like microRNA. And in the human cells, there are about 35,000 transcripts, including, of course, alternative splice variants. So that's the definition of transcriptome, and the definition of transcriptomics is the study of transcriptome. So profiling the scope, transcriptome is the transcriptomics. How can we study the transcriptome? There are two kind of categories. The focused approach, which comes from the reductionist point of view. If you have a gene of interest, you use Northern blot or real-time PCR to examine the expression profile of that gene. Now, when we talk about systems, when we talk about networks, it's the high throughput approach. There are two categories of the high throughputness approach: closed system and open system. The most popular closed system for high throughput approach is the microarray, and for open systems there are SAGE, MPSS, massive parallel signature sequencing, and RNA-seq. Microarray, very simply, you have two conditions. You isolate the total RNA from the two conditions. You label the normal, let's say, with a green dye, and the cancer with red dye, Psi5 and Psi3, and you hybridize the two samples on a chip, and you excite the samples with laser, okay, and you get the color red from the condition, from cancer, and green from the normal. You overlay the two images, and you look at the color after overlaying the two images. Of course, you know that like if after overlaying it's a green, so that means that the gene is highly expressed in normal compared to the cancer. If it's red, the gene is highly expressed in cancer compared to the normal. If it's yellow, then there is no differential expression between the two conditions. The gene has the same level of expression. Okay, so that's a very overview of microarray. Here's the human chip, and that's the print which prints the sample on the array. Advantage of microarray is it's a small, it doesn't need much of RNA, it doesn't have bias. Again, you don't have a gene of interest, you do it on a genome-wide scale, and when you do the experiment, you generate so much of data, so you can generate new hypotheses, and you can follow up with your hypothesis with further experiments. The disadvantage of microarray is a closed system. So the array is designed based on the known information of the genome. So they know the genome, they know the transcripts, and they print the transcripts on the array. So again, the array will give you only the expression of the genes that are known. Tiling array is another technique for high-throughput gene expression profiling. So the advantage of microarray of tiling array is that the design of the probes covers the entire genome. So it's not specific only for the known transcripts. They design the probes to cover the entire genome, the DNA itself, and they collect the RNA, they hybridize the sample, they hybridize the chip, and they look at the expression file. So the idea here is to maximize the coverage of novel transcripts or novel alternative splice sites. The disadvantage of tiling array is going to be much more expensive than microarray because you need to design probes for the entire genome. The novel approach now is the RNA-seq. So RNA-seq, it means that we sequence the transcripts. Okay, so there is no hybridization here. It's based on sequencing the transcripts in the cell. Again, extracting RNA, put the RNA, reverse transcribe RNA to cDNA, put it on the sequencing machine, and look at the counts of transcripts in the cell. The advantage of RNA-seq is that you profile gene expression. You can predict novel genes, novel exons, novel alternative splice sites, isoforms. You can predict cases of gene fusion, post-transcriptional mutations, and single nucleotide polymorphism. The major players in terms of next-generation sequencing protocols are these three machines: 454 from Roche, Genome Analyzer from Illumina, and Solid from Applied Biosystems. They are different in terms of productivity or in terms of throughputness.
So 454 generates about 1.2 million reads with an average read length of 400 base pairs. Our genome analyzer, 160 million reads, but with shorter read length. Solid 1 billion reads with much shorter read length, only 50 base pairs. At EUC, we have the 454 sequencer in our genomics facility. Again, the experiment for RNA is simply you isolate the RNA, reverse correct to cDNA, and then you fragment the cDNA into small fragments. You sequence the fragments into reads using one of the 3 machines, and then you map the reads back to the genome. So in our case, it's going to be the human genome. You generate the reads and map them back to the human genome. When you get the reads, you count the mapped reads to the reference, and the count will give you the expression level of the gene. Okay, so here, for example, we have the position on the gene, the position of the genome, and the y-axis is the level of expression. And we can easily see that this represents one gene with one intron. Okay, so here's a small exon intron because there is no expression, no reads mapped to that region, and then one big exon followed the intron. Using RNA-seq, again, we can determine expression level by mapping the reads to the exons. We can, so here's a picture just showing that if we know that our gene has 3 exons, 1, 2, and 3, and after doing the RNA-seq experiment, we found some reads mapped to another fragment in the genome after the exon 3. So we can say that actually there are one more exon 4, for example, and there is an intron between 4 and 3 that wasn't predicted before, or that wasn't known before. Same thing, detecting expression profile using RNA-seq. That study, they use RNA-seq on different cell lines, and in the human genome, they identified 4,000 novel splice junctions out of 3,000 genes by doing, again, RNA-seq.
1 minute remaining.
Okay, so we'll quickly jump into personalized medicine. Why different drugs will not have the same impact or effect for different people? So age, ethnicity, weight, gender, coexistence of other diseases or drugs, social factors, experiments, and the genetics, and that leads us to personalized medicine. Personalized doesn't necessarily mean person by person, but it's more like population by population. Okay, so concerning our population, the Egyptian population, we don't have much of genomic database, genomic reference that we can refer to and compare it and assess whether the drugs are designed based on work that's published based on other populations fits our population or not. So we have our ambitious project with
Your time is up.
with Dr. Galad to do RNA-seq based experiment on breast cancer Egyptian patients to collect the data and build our first genomic database based on the Egyptian population. And so that's one aim of the project. The other aim is to, again, of course, to do gene expression profiling and look for SNPs that are associated or specific for the Egyptian population. Again, to look for cancer biomarkers that SNPs or genes that are specific to our population. And thank you.
Thank you very much, Professor Ahmed. Now we'll move to our next speaker, Professor Jalal Al-Fresh. She's a professor of clinical pathology, and she will give us a talk about the role of blood in cancer breast.
Actually, nothing left for me. Everything will be repeated. So I hope that you take it easy. I'm just going to summarize what has been said before. So I talked about the role of blood in cancer management. certified from the International Agency for Research on Cancer. And this is an incidence rate, according to the glucophane as well, of 18.3% and a mortality rate of 12.9%. What about the management of breast cancer? I think prediction would have a major role to prevent. If otherwise, we have to diagnose and to guide the line of treatment and to, again, predict the outcome of these treatments in addition to the evaluation of the test. So, does the lab have role in this management? Yes, on two different bases. The first base, which is really applicable, it's according to the clinical application, so we can identify genetic risk in high-risk women, detect and diagnose breast cancer in its early stage, determine how far it has been spread, evaluate the cancer characteristic in order to guide the treatment, monitor effectiveness of treatment, address any cancer recurrence. This is actually applicable. Again, the role of lab is also in the research to update and to develop new biomarkers, new genes and gene controls, and new pipeline modalities for the treatment, which actually all my previous colleagues have mentioned some about this. So, what about prediction? Prediction, we have the genetic testing for two very famous genes, which is the BRCA1 and BRCA2 genes. In addition, a non-laboratory approach which is very much emphasized according to Dr. Ala, which is self-testing and the mammogram. As regards BRCA1, BRCA1 combines with tumor suppressor genes and as well as DNA repair genes in addition to BRCA2, and they form what is called the BRCA1 associated genome surveillance complex, which play roles in transcription and DNA repair and recombination. As regards diagnosis, yes, the lab has of course a role, but the pathology lab and not the clinical pathology one. So a fine needle aspiration cytology can be done for diagnosis, as well as the gold standard histopathology by a surgical biopsy. What about the treatment guidance? Treatment guidance, according to the expression profiles of the tumor cells, so we have to evaluate the HER2/neu gene amplification and the estrogen progesterone receptor status. As regards the HER2/neu is a member of the epidermal growth factor receptor family of tyrosine kinases. When it binds with other members of the same family, it forms a heterodimer, and this enhances the kinase-mediated activation downstream signaling of nitrogen-activated protein kinase and phosphoinositol kinase, and amplification or overexpression of this gene has been reported in numerous cancers, including the breast cancer. Actually, this cartoon is coming from prostate cancer. Well, HER2/neu may be involved in determining chemosensitivity. It has also been implicated in the development of resistance to anti-estrogen tamoxifen therapy, and the new monoclonal antibody receptor is the approach for patients expressing HER2/neu on the cell surface. As regards estrogen and progesterone receptor status, which is done mainly by immunohistochemistry, the CAP of the American College of American Pathologists has some guidelines for this test. It includes that the ER and progesterone receptor status should be tested for each patient newly diagnosed. So Dr. Basma ER positive or PR positive if at least 1% of the cells examined are immunoreactive to this antigen. Testing is best done on larger tissue samples, and if cancer has spread, testing also should be done on samples, metastasizing samples. Laboratory, which is also included in the guidelines, which concerning the quality control of the samples. So laboratory testing for ER and PR should be accredited by the CAP or meet the additional accreditation requirements in the guideline and show agreement with other validated ER and PR tests for both positive and negative results. And the laboratory must be inspected every 2 years to be sure that the testing methods conform to the guidelines required. Again, this is what is a dilemma can occur if we have this ER peritoneal crosstalk. How this comes? So it's not only if it is ER, it has the line of modality, and if it is peritoneal, it has another line of modality. You can have a combined line of modalities, and Dr. Alak actually mentioned lots of this. So for estrogen activates nuclear ER, and in the same time activates a membrane or non-genomic pathway of the estrogen receptor. Membrane-associated estrogen receptor binds to growth factor signaling components such as phosphoinositol kinase. E2 then activates growth factor signaling, activating chemomolecules such as the ACT or RAS, and downstream molecules such as mTOR, RAS, MEK, and MAP kinase, membrane associated. In addition, signal transduction molecule can phosphorylate and activate the ER and its co-regulator to enhance the nuclear genomic ER mutated. So there is a crosstalk between both mechanisms. To monitor the treatment, this is the traditional way to monitor the treatment is by the estimation of the level of carbohydrate antigen 15-3 or the less common carbohydrate antigen 27-29 in the blood. So carbohydrate antigen 15-3 is a protein produced by normal breast cells. In many patients with cancerous breast tumor, there is increased production of this protein or its related antigen 27-29. It does not by itself cause cancer. It is shed by the tumor cells and enters bloodstream and in abundant amounts of measure. Its disadvantage that it is present or it's high in only 10% of women with adrenal-localized breast cancer and mostly high in women with metastatic breast cancer. It may be elevated also in other conditions, even in healthy individuals or other cancerous conditions. Prediction outcome, we have the two new diagnostic genetic or gene imprints. The one which is called the Oncotype DX and the other one is the MAMA. I'll go through it. This is the website of the Oncotype, and actually it's only one laboratory that do this type of reaction, and they introduced also an Oncotype for colon cancer, and this is also in the website. So what is an Oncotype DX? It's a 20-gene expression profile that measures 16 cancer-related genes. Dr. Alak already mentioned this, and we have 5 reference genes to verify that the test has not to be contaminated or run improperly, and all, of course, the 5 reference genes are actually housekeeping genes. On the other hand, the 16 genes which produce their protein at varying level in different tumors include genes that is concerned with proliferation, like cellular invasion like the stromolysin, sepsin. Again, HER2 activity and its related genes, estrogen activity and its related genes, and other genes that distinctly different with different activity in cancer cells. The three one mentioned below. What it evaluates? It evaluates the likelihood of breast cancer recurrence and assess the benefits of adjuvant chemotherapy. Newly diagnosed patient who should be tested for with this oncotype. Of course, first of all, it should be rich person. But anyway, it's a newly diagnosed patient who has stage 1 or 2 cancer that is estrogen receptor positive and lymph node negative, and who will be treated with tamoxifen, the famous anti-hormonal therapy. What is the kind of specimen? It's the formalin-fixed paraffin and tumor tissue. What is the methodology run here is a real-time quantitative PCR for the detection of the transcriptions of these the above-mentioned genes. So at the end, what's the result come with? The results come with what is called a recurrence score between 0 and 100. Less than 18, with a score less than 18 defined as low risk of distal recurrence within 10 years. Greater than 31 is a high risk of recurrence, and between 18 and 30 is an intermediate risk. Patients with high risk score are more likely to benefit from adjuvant chemotherapy. The other test is the mammogram, which is used now in Europe and it's FDA certified. This is the website of the mammogram, which is called Symphony Personalized Breast Cancer Genomic Profile. Actually, this was a paper published in 2006 with the first trial of these tests. They used a microarray technique and they produced a heat map with a stratification, as mentioned by Dr. Alain Basma, according to the expressions of the genes in the tumor versus in normal tissue. Back to the research, I would like to present our research. We think about this gene expression profiling because going through the internet we find lots of papers about gene expression profiling. However, nothing came from here. Actually, it was one article and it was only about what is called reduced or one gene component. Our research objective is to establish a gene expression profile for de novo breast cancer Egyptian cases. Our secondary objective would be getting a baseline reference data set of normal breast tissue. So, because we have to compare normal with abnormal, revealing frequency of ER, PR, and HER2/neu, because this is our categorization points among the studied samples, discovering the difference of the gene expression between different conditions according to the expression of these parameters, and lastly, comparing our data sets with other data sets published on the internet, which is the function of our dear Ahmad Mustafa, the bioinformatician. So this is the method. We will have, of course, to do histopathology for grading and, of course, surgical staging, immunohistochemistry with ER/PR, then DNA and RNA extraction and detection of HER2/neu gene expression, and lastly, deep sequencing of the RNA using the FLX254 sequencer in the American University of Cairo. This is an example of a website for bioinformatic database, and of course, as I said, we go through this after getting our own database, which is still going on here. So what is the scientific importance of this? This will be the first mentioned data set from Egyptian population, which will confirm or disagree with other published data sets for breast cancer, and hence would modify our prospect as regard unique profile and how to deal with. Thank you.
Thank you so much, Professor Jalal. I think we have a few minutes for questions and comments. May I ask our speaker to come to join us in the floor is open for any question or comments. Any question? Well, I'll start by asking Professor Ala about screening by mammography. What is the ideal age for screening? It's an issue right now. And how long the screening is?
Well, thank you very much, Professor Abbas. This is an excellent question, by the way, actually. There's no consensus worldwide about the age at which age should screening start. Like, for instance, in the States, the cutoff age is 40 years. In the UK, it's 50 years. In Sweden, it's like the US. However, what I always say that we have to decide after we do our homework what type of age limit, which age limit should we start our screening program. Most importantly is to emphasize of the idea of breast cancer awareness, because this is extremely important. The idea of screening itself has a psychological barrier with women everywhere, and that's more increased in our area, not in Egypt also, in the whole Middle East and third world countries. We should emphasize that and take off the dogma from the minds of our women, because this is really life-saving. So if we do breast awareness, do clinical examination, we will find, and I'll tell you actually, in those 4,000 women that we did in this slum area, we could detect very early cases, and those patients were treated actually in our hospital here. So we shouldn't wait till we have all the resources to have mammography in all units, as we do for immunizing our children, for instance, from whatever type of disease, because when you invest in screening, you save lots of money in treatment.
Yes.
I'd like to thank all the speakers today for their interesting lectures, and my question is to all of them. Okay. Now we anticipate that the diagnosis of breast cancer is not just taking a specimen, look into a microscope, and find our decision. I knew from your lectures that we have a lot of something we can do in the lab, and especially in the field of molecular biology. I want every woman in this hall and every doctor now is concerned about what is our guideline to go through from the first suspicion in the patient to reach the optimum benefit for diagnosis and treatment in a simple way, one by one, if we can reach to this guideline.
As pathologists, we are not by any means first lines. So our patient is most likely to confront a clinician before he addresses us. but we do receive excision specimens for non-worrisome, non-clinically worrisome lesions, and we do find accidental cancers, most probably in early stages. We warrant the surgeon and we summon up the patient and we continue the cycle, but I do not think the pathologist is likely to play a beneficial role in a screening program or an early discovery program. Of course, apart from a well-devised program in which the clinician spots a mass and then assigns the patient to a fine needle or to a guided fine needle, something or nipple discharge exam or something. But before that, we are not likely to meet her before others do.
Just want to add, I won't go through the details of Dr. Salah because the question is extremely important. I mean, I think the key is the teamwork. Unfortunately, we don't work together, unfortunately. So if we work together, we will have guidelines for every single step, starting from screening till treatment. I mean, I'm talking about surgeons, oncologists, pathologists, clinical pathologists, radiologists. This is the issue.
Yes. I agree with what Dr. Alaa just said, that we need multidisciplinary team in all our cases because the best treatment we give to our patient, first starting by early detection and aiming for cure, not just for treating it. Any comment?
Well, I think the answer for Dr. Salah is on the Mayo Clinic website. You can go for an algorithm for breast cancer, how you can manage it. So it's very simple and easy. You can go there and there is the way. But as they mentioned before, that it is a combination of more than one team, the surgical, the pathology, the lab, and everything. So I think if you go to this site, and there is a lot of things on this site. It's a site for the Mayo Clinic.
Any further?
Dr. Alaa, how you can monitor the response to treatment? You say that you try treatment, and how you can monitor the response?
Well, that actually has so many categories. If you're talking about a patient with an intact tumor that has not gone surgery, so what we have right now is you monitor on clinical basis, like you do clinical examination in addition to radiological examination, whether mammography, ultrasound, plus or minus MRI. But what you're talking about, or what I was talking about, is this the way for more research is that you monitor on molecular level, and unfortunately, the only way is to do that is to take the tissue out, which is mean surgery, okay? Because it's not only me, but I'm thinking out loud. Not all our patients do need surgery. Some breast cancer can be treated without surgery, okay? And not all our patients need chemotherapy, nor hormonal therapy, nor therapy, because this is the way we've been treating cancer breast or all other types of cancer. But from the data you've seen, for instance, like patients who achieve complete pathological response, they don't need surgery. Unfortunately, the only way to know those patients is to take this tissue out and examine it pathologically. If we have another tool, like they're working now on PET scanning or some types of MRI or spectroscopy or so, to measure what's left and then to decide. Actually, there is a very famous paper that came out from the Royal Marsden, which is the #1 cancer center in the UK and in whole Europe. And the title of this paper, Do We Need Surgery? And they did that, actually examined some patients with neoadjuvant chemotherapy. Half of them went to surgery, half of them didn't go to surgery. And in that study, actually, however, that was not a randomized study, by the way. There was no difference in the patients who do respond. So I'm not saying that we should omit anything. I'm not saying that. But monitoring the patients, as you mentioned, will save lots of patients, lots of treatment, and add more treatments to some patients. Because, as we all mentioned, all the speakers, breast cancer and any other cancer is not one disease. It's multiple diseases under only one single category, but they are completely different.
ينفع اتكلم بالعربي؟ هو اولا انا اسمي تقي. والدتي توفت بالبريست كانسر من 11 سنه، وانا حابب اقول بس ان موضوع التوعيه الصحيه بالبريست كانسر هو اهم ما نستفيد منه من المؤتمر، ان تتوسع عمليه التوعيه الصحيه على جميع محافظات الجمهوريه. انا مشترك في مؤسسه اسمها المؤسسه المصريه لمكافحه سرطان الثدي، بريست كانسر فاونديشن اوف ايجيبت، والمؤسسه جميله يعني بتشتغل وعندها بروشورز كتيره، يعني ممكن يبقى فيه كوبريشن برضه هنا في اسكندريه. تاني حاجه لازم احنا بنتكلم عن البريست كانسر يبقى لازم نذكر الجولدن نانو بارتكلز ان diagnosis and treatment of breast cancer as new prospective and new technique discovered by دكتور مصطفى السيد وهو مصري، وان الموضوع منتشر جدا هنا في مصر طبعا. كان لابد من وجود توك حتى تقول ان نيو بروسبكتيف الحاجات اللي احنا ممكن نتوقعها في الفيوتشر علشان نعالج. يعني تشاينا وامريكا ويوروب كلهم بداوا يشتغلوا واحنا لسه يعني في بدايتنا. دي النقطه اللي انا كنت حابب اوضحها.
شكرا جزيلا على التعليق. انا بدعو حضرتك ان انت تنضم للمؤتمر قسم علاج الاورام في شهر 10 ان شاء الله. هتلاقي موضوعات تهم حضرتك يعني. الحاجة الثانية ان دلوقتي في معظم مؤتمرات الاورام بيبقى فيه جزء بندعو المرضى واهالي المرضى عشان يتكلموا ويقولوا الاراء بتاعتهم في طرق العلاج وطرق المانيبيوليشن المختلفة. اشكر حضرتك. Any more questions for yes?
سؤال الدكتور هيا. اولا حضرتك الاستادي اللي هي على الساوند اريا، حضرتك قلت ان ده فعلا حصل في ريزم اويرنس according to some tools، يعني استخدمتوها مش كده؟ طيب انا كنت عايزه اعرف الريسبونس بتاع السيدات هناك في موضوع السيلف اكزامينيشن او فرض الواب، and what is the tool you have
انا بشكر حضرتك على السؤال. هو انا ما رضيتش بس طبعا عشان السيك اوف تايم يعني احط التفاصيل كامله. البحث ده احنا اوريدي قدمناه في هو 12 في المانيا واحنا قدمناه في NCCN يعني. المهم عشان بس تعرفوا قد ايه حضرتك الموضوع ده مهم، ان البيست اويرنس ودي حاجه يونيك جدا بالنسبه للموضوع ده بالذات يعني، او يونيك بالنسبه للسيدات يعني. مش هتصدقوا ان نفس الكونسيرنز اللي عند استاذه الجامعه هي نفس الكونسيرنز اللي عند السيده اللي هي بسيطه جدا ومش متعلمه. ومش هتصدقوا ان نفس الاسئله اللي لو قعدت حضرتك تشرحها الموضوع كله بتاع البريست كانسر والاويرنس والدايجنوزز والكلام ده هي نفس الاسئله اللي هتسالها هنا، ونفس الكلام اللي هيطلع ونفس الكلام اللي هيطلع. فالايديا كانت ان احنا بنروح الاول بنقعد معاهم في مجموعات بنديلهم محاضرات يتكلموا عن الكانسر ان جنرال، بيتكلموا عن البريست كانسر، لان اغلب الناس دي عندها معلومات كلها مغلوطه ما هياش حقيقيه على الاطلاق. فلما بيفهموا وبيسالوا وبيشوفوا الاجابه مقنعه بالنسبه لهم، وبعد كده بنعمل لهم اكزامينيشن فور فري، ومنهم ناس كنا جايبين فلوس من NGOs بنعمل لهم ماموجرافي فور فري، ودولت الناس اللي كان عندهم فيري ايرلي ديزيز والحمد لله اتعالجوا بدري. بالاضافه ان احنا بنعلمهم على موديلز البريست سيلف اكزامينيشن. على فكره انا مش من الفانز ولا من مؤيدين البريست سيلف اكزامينيشن، بس مضطر ان انا اقوله ليه؟ لان هو حتى كان في الامريكان كانسر سوسايتي جايد لاينز زي ما قلنا الكلينيكال اكزامينيشن باي ذا فيزيشن والماموجرافي، وكان في بريست سيلف اكزامينيشن. لو لاحظتم الموست ريسنت في بين قوسين كده بين براكتس اوبشنال خلاص بريست سيلف اكزامينيشن. ليه؟ لان هو وجد ان هو it raises more panic than assurance. البريست نفسه الاكزامينيشن بتاعه ما هوش سهل على الاطلاق على عكس ما الناس متصوره. يس اتس اكسترنال اورجن، لكن الاكزامينيشن بتاع انه لامبي بريست فيري ديفيكلت. نمره 2 لانه عضو متغير على مر السنين بالنسبه لاي سيده وهي في سن الدوره وما بعد الدوره وما قبلها، وهي بترضع ولا ما بترضعش بسهوله. زي ما الدكتوره دلال بتسال، لما ونعلمهم البريست اكزامينشن هم نفسهم بيبقوا اكسايتد ويبتدوا يتعلموا ويبطلوا يخافوا، ومره تيجي بعد مره في الثانيه الموضوع ده على فكره اهم حاجه فيه الاستمراريه. لا ده كانت خايفه مجرد انها حاسه بالموديولاريتي بتاعت البريست بتاعها لما بتطمن انها ما فيش اي حاجه اند سو اون. فكان الموضوع على مستويين، ان احنا بنسالهم على حاجات كانوا بيجاوبوها بشكل معين في الاول، وبعدين جاوبوها بشكل تاني احسن كتير جدا، النولج بتاعهم بقى رائع، وده كان significantly improved. ونمره 2 اللي هو الالتزام بالبريست اكزامينشن بتاعهم، والاهم من كده ان هم كانوا بيجيبوا ناس تانيين. يعني هو النجاح ان هم ما دام ما خافوش وفهموا وعرفوا، كان النجاح الحقيقي ان هم بيجيبوا صحباتهم او قرايبهم او حاجه ثانيه. على فكره اللي عملت الاحصاء كلها جزء بالمناسبه.
طيب كنت عايز اعرف what is meant by potential novel action and potential novel error في last talk, and how can you detect this potential
دكتور احمد اكتر منه.
So the technique is based on sequencing the transcripts, right? So we are not constrained by the known transcripts from the human genome, which is the reference now. Because we're going to sequence the transcripts that are available in the cell, we will match the transcripts, all transcripts, back to the reference, and this way we can discover transcripts that were not known before. We can find new exons, we can find actually whole new genes. Again, the idea is that we are not constrained by the mode. We sequence, we get what we get, and then we map. By mapping, we can identify novel SNPs.
part in the gene extended than the normal maps we have?
Yes. That's the idea, and that's the advantage over doing microarray, because microarray is limited by what is known based on the reference, which is not, of course, it's not fusion. It's wide American guide. That is the reference genome. So we want to build our own database so we can identify the markers that are specific to the rejection population.
But if you said it is an exon, you have to detect a function from this exon.
Sure, that's going to be another story. Yes, we can detect the existence of novel molecules, but the prediction of the function that's going to be another story. Yes.
Thank you.
Please, Dr. Ala, can we use circulatory tumor marker for follow-up the treatment? Like microRNA or circulatory tumor cell?
يعني انا مش شايف لحضرتك سؤال. طبعا السي تي سي او السيركيليتنج تيومر سيلز مش بس في البريست كانسر، في other ecological entities زي prostate cancer are coming more and more increasing. However, they're not in the guidelines so far. But at the time of the diagnosis and for the follow-up and response to treatment, yes, there are lots of research, ongoing research to use that as a tool to evaluate the treatment and to stage the patients by measuring the circulating tumor cells.
I'm sorry, I have another question. Sorry.
We have
okay.
We have no time for further questions. Sorry. Finally, at the end of this session, I'd like to thank so much our speakers and our audience, and I invite the chairperson of the other session to start. Thank you very much.